Assalamu alaikum. Good evening, everybody. Welcome to the third copy of the series of the webinars in thyroid disorders. My name is Dr. Tariq Al-Had. I'm senior consultant endocrinologist, and at the same time, I am a board member of the Gulf Association of Endocrinology and Diabetes, on behalf of which this series of educational sessions has been delivered. Currently, I am the president-elect of the organization, and it gives me great pleasure actually to moderate tonight's session, which is actually entitled Thyroid in Adult Disorders. Actually, we are welcoming three eminent speakers. The first of them is Dr. Ahmed Al-Qaisi, and who will start a very fascinating, actually, sort of program by giving us a presentation on Graves' eye disease. Dr. Ahmed Al-Qaisi currently is a consultant endocrinologist working at the Imperial College London Diabetes Center based in Abu Dhabi. He qualified from Iraq, and then he pursued his higher medical training in the United Kingdom, where he practiced actually as a consultant endocrinologist in Leeds Teaching Hospital. Dr. Al-Qaisi has been actually running a very dedicated thyroid service in Leeds, and he has been quite active actually in research and academia. Dr. Al-Qaisi will give us a presentation about Graves' eye disease. With further ado, the platform is yours, Ahmed. Tfaddal.
Thank you, Dr. Tariq. Assalamu alaikum and good evening, everybody. Thank you for attending in such a late time. I'll share my screen. So I'll start my talk by just explaining my aims. I'll speak about the epidemiology of thyroid eye disease. We'll talk a little bit about pathophysiology and talk about the signs and symptoms expected with thyroid eye disease. We'll talk about the activity and severity scoring system that we use, what investigation we do, what is the available treatment, and what is the future emerging treatment. So as we all know, thyroid eye disease is an orbital inflammatory disease that could be associated most of the time with the Graves' disease. However, sometimes is associated with Hashimoto thyroiditis. Sometimes we've seen patients where they have positive TSH receptor antibody with a normal thyroid function test. Majorly, it can lead to significant proptosis and visual impairment. And obviously, because of this, it can lead to a reduction in the quality of life. Graves' disease affects 20 to 50 people per 100,000. It affects women more than men. The thyroid eye disease is the same pattern, affect ladies more in a form of 16 to 100,000 compared to only 3 for men. However, men get usually more severe disease compared to women, of which they get more frequent disease of the thyroid eye. When orbital imaging been done with all patients with the Graves' disease, even if they didn't show sign of thyroid eye disease, 70% of the patients showed some subtle changes at the back of their eyes with the CT and MRI orbits. A little bit about pathophysiology. I'm not going to make it complex, but I thought this is a very nice sort of illustration of the pathophysiology. The involvement of the pathophysiology are mainly from T cell, B cell, thyroid stimulating antibody, and the new emerging IGF-1, which we only discovered a few years ago now, together with all the cytokines lead to activation of the resident fibroblast. The resident fibroblast can lead to more production of hyaluronate and inflammatory reaction, and will be differentiated more into adipocyte and more muscle cells of myofibroblast, This will all lead to orbital expansion from fat and from the muscle, and lead to expansion of the volume at the back of the eye, leading to proptosis, inflammatory changes, and optic nerve compression. The major signs and symptoms of the thyroid eye disease is lid retraction, as we're all aware. We've seen even some patient who has ptosis, and this could be an association with myasthenia gravis. It is rare, but it did happen before. Proptosis is a well-known, mainly because of the increase in the tissue at the back of the eye, and because of the increase in the muscle size and the tissue at the back of the eye, there will be extraocular muscle dysfunction in the form leading to double vision. Periorbital edema because of the inflammation, corneal ulceration because of the lid retraction, chemosis also because of inflammation, which is conjunctival edema, exposure keratitis because of the lid retraction, and obviously because of more cramped tissue at the back of the eye, there will be compression on the optic nerve leading to optic neuropathy, and unfortunately sometimes blindness can happen. We are all aware of Rundle's curve. Rundle's curve is just showing us how thyroid eye disease progress through the time. Thyroid eye disease start by active inflammatory phase, of which this phase can last 1 to 3 years, depending on some certain factors. After the active inflammation, there will be long-term chronic fibrotic changes to the eye. And as expected, earlier treatment can lead to less chronic fibrotic changes. More later treatment can lead to chronic fibrotic changes, not much of a change compared to earlier treatment. So if we start the treatment earlier, you can see on the curve, and we will reduce the active inflammatory phase, leading to less chronic fibrotic changes in the future. And this is also an illustration of the same thing. As we said, 1 to 3 years active phase. Earlier treatment will lead to much less effective long-term chronic changes. Even if we use emergency decompression and eyelid surgery on long-term, it doesn't reduce the chronic changes in the future. While earlier treatment can lead to even no need for any surgical rehab in the future. Risk factors that can lead to more severe disease or longer or more severe active phase is smoking, increasing age. As we mentioned, also gender has importance. Women, as we said, has more frequent disease, but men has more severe disease. Radioactive iodine, as it will lead to destruction of the thyroid and leakage of all the immunoglobulins and thyroglobulin outside, leading to more immune response from the body, leading to changes at the back of the eye, high T3 and high TSH receptor antibody. The European group on Graves' orbitopathy had a clinical activity score system that we use in Europe. Each point will get 1 score. There are 7 points at the beginning of the classification, and then after 1 to 3 months with the review, it will go up to 10 points. These points are spontaneous pain in the orbit, or gaze-evoked orbital pain when the eyes is moved. Obviously, eyelid swelling will consider as a point, or erythema. The conjunctival redness by its own, not necessarily by swelling, will have 1 point. Chemosis, which is the conjunctival swelling. The inflammation of the caruncle or plica, and we will see it at the eye in a minute. And after the patient will return back, our ophthalmology colleague will also help us in the pointing system, of which if there is an increase of 2 millimeters of proptosis, we'll get 1 point. A decrease in uniocular excursion and a decrease of the visual acuity also will get 1 point. The 3 to 4 points or above will consider the patient to have active thyroid eye disease. This is just an illustration how chemosis can happen, and you can see there is not just inflammation, but the swelling of the conjunctiva. And this is just a reminder where the place of the caruncle and the plica in the eye. So redness and inflammation in this area will consider to be 1 point in the CASA scoring system, even if the rest of the eye looks clean and not inflamed. The European Group on Graves' Orbitopathy classify thyroid eye disease into mild, moderate to severe, and sight-threatening classification. The benefit of the classification is to differentiate the management between each group. Mild thyroid eye disease is usually, from its name, mild impact on daily activity. It is insufficient to justify immunosuppressive or surgical treatment, and it is diagnosed with one of the following criteria or more. If there is mild lid retraction of less than 2 millimeter, or if there is a soft tissue involvement but in a form of a mild way, if there is exophthalmos less than 3 millimeter per the race, if there is a transient or no diplopia, and if there is corneal exposure that is responsive to some lubricant that we use. While on the other side, the moderate to severe thyroid eye disease, it is non-sight-threatening, but it is sufficient to have enough impact of life that will justify our use of immunosuppressive or surgical intervention, and is diagnosed by one or more of the following, all the points that we mentioned before, but in a more aggressive way. So lid retraction more than 2 millimeter, moderate or severe soft tissue involvement, exophthalmos more than 3 millimeter, and transient or constant diplopia. Now, the sight-threatening thyroid eye disease, from its name, because there is a compression on the optic nerve, it could lead to optic neuropathy and or corneal breakdown. And this will warrant, obviously, an immediate intervention. What investigation we do? The investigation mainly help us in reaching the diagnosis and try to think of the differential diagnosis. So we mainly do thyroid function tests. The aim is to make the patient an euthyroid. We do the TSH receptor antibody as we can predict the severity of the thyroid eye disease. We do inflammatory markers, and most of the time we end up doing orbital imaging in a form of CT or MRI scan, which is more gold standard, especially if there is a unilateral disease, to help us in the differential diagnosis. And the differential diagnosis is mainly myasthenia gravis, any form of orbital involvement and the form of inflammation, inflammatory orbitopathy or myositis or tumors, or carotid cavernous fistula, which cause more of a unilateral disease. Now, for treatment, for mild thyroid eye disease, we aim to make the patient in a form of euthyroid status. Smoking cessation is very important, as smoking or even secondary smoking will make the active phase more severe and longer, hence will cause more chronic changes in the future. Head elevation help in the reducing the swelling in the eyes. Artificial tear, lubrication, ointment help. Oral non-steroidal, especially in the form of ibuprofen. We did use selenium in our clinic before. The study on selenium was using 100 microgram twice daily dose, and it showed an improvement in the clinical activity scoring system of around 1.3 points at 6 months. No major difference when they were used for up to 12 months. And it showed improvement in the quality of life. So we use it in our clinic mainly in one dose in a form of 200 microgram, and we only use it for 6 months. Other form of treatment for thyroid eye disease is thinking about when we applied for the pathophysiology. And I thought I'll just use this slide to put all the medication, and you can see the mode of action of each medication. So, for example, the major medication that we use as first line is the steroids, and steroid has multiple action on the fibroblasts, reducing inflammation, effect on T cell, effect on B cells. Other medication that we use, cyclosporin can have direct effect on T cells, mycophenolate can have T and B cell effect, rituximab can have B cell effect depletion on B cells, methotrexate can have tumor necrosis factor effect, IGF-1 receptors medication like octreotide, lanreotide didn't show much effect. The new medication that's been approved in 2020 by FDA, teprotumumab, work on IGF-1 receptor. Pentofixylene nicotinamide, never used it before. It's not that much effective. We'll talk about each medication in more details, but I thought I'll just put it on the pathophysiology slides and help us in understanding how they work. So the first line medication that we use is systemic glucocorticoid. Study done by Cahaley in 2005, where he randomized patient whether to use intravenous methylprednisolone in one arm as 500 milligram per once weekly dose for 6 weeks, then 250 milligram once weekly dose for another 6 weeks, compared to the other arm, of which they used oral prednisolone, but quite a fairly big dose of 100 milligram per day and tapering by 10 milligram per week. And you can see from the result of the study on the right lower side of the slide that there is a clinical significance in the group that use intravenous methylprednisolone compared to the oral steroids. And obviously, steroids have side effects, mainly all the side effects that we are aware of. I'm not going to go through them. We see maybe less side effect on the pulse once weekly IV medication compared to the oral medication. Cyclosporin as a second line medication, mainly 2 randomized controlled trials were done. It didn't show any superiority to pair oral steroids. However, a combination with oral corticosteroid and cyclosporin was more superior compared to oral steroid by its own as a single agent. It hasn't been tested before with IV steroids. Be aware of some side effect, mainly increasing blood pressure. Once we discovered IGF-1 as part of the pathophysiology, everybody was excited about using lanreotide or octreotide. 4 randomized controlled trials well done. However, it didn't show much effect and it is not generally recommended. Mycophenolate mentioned in the UGOGO guidelines, it is used not as a second line, but rather as an adjunct to the glucocorticoid medication. It acts by suppression of the action of T and B cells. Main study that explored that, called Mingo study, it classifies 2 arms for patient, 1 arm receiving only intravenous methylprednisolone alone, and the other arm in combination with mycophenolate. It didn't show any difference in the response of both arms up to 12 weeks. However, after the 12 weeks, once the intravenous methylprednisolone were stopped, the arm where it used mycophenolate showed more reduction in the clinical activity scoring system. Other immunotherapies, monoclonal antibodies like tocilizumab, it's an anti-interleukin-6 receptor monoclonal antibody, block interleukin-6, used in rheumatoid arthritis. The main study was tried on steroid-resistant patients, and you could see compared to placebo, it showed superiority in reduction of the clinical activity scoring system. Rituximab is a beta cell depletion. 2 major studies were done. One used it as in 4 doses once weekly, another as 2 infusions over 2 weeks. One study showed superiority, another study didn't show superiority. None of the studies show any improvement in proptosis. We did use it in our clinic in a few resistant cases, and it did show some good results. The new agent that had been approved in 2020 showed very promising result on the earlier stages. It's called teprotumumab. It's a monoclonal IGF-1 receptor antagonist. The study, as you could see, the result is very significant compared to placebo, and it is the only medication that is available that could reduce proptosis more than 2 millimeters. However, a recent study from Cleveland Clinic in Ohio is showing that once the teprotumumab stopped, there might be some reactivation of the thyroid eye disease. Their study involved 21 patients were included, of which 17 patients responded very well to teprotumumab initially. However, 8 of these 17 patients were reactivated. The response really to teprotumumab in 24 weeks is almost 33% and not as showed in the research earlier. However, teprotumumab, I feel it's opening like a Pandora box for us to try a future agent that could help in the thyroid eye disease problem. Orbital radiotherapy, very effective treatment. However, it takes 4 to 6 weeks to start to have effect. It is usually used as a small dose of radiotherapy of 15 to 20 gray in 10 sessions. It is as equally effective as a corticosteroid. However, it does take time to have effect on the ground. It has side effects, as you're all aware, from radiotherapy like dry eye, retinopathy, optic neuritis, and secondary malignancy. Surgical rehab, once we are crossing the Randall's curve, as you all saw, we will have some chronic long-term problems and signs. Surgical rehab will help in trying to reduce these signs and symptoms in the form of orbital decompression, strabismus repair, or eyelid repair. It could be required as much as 80% of the patient reaching to moderate to severe disease. The sight-threatening thyroid eye disease, obviously from its name, we need urgent treatment. IV steroid, surgical decompression are the management of choice. It's not very frequent. It's almost 5% of the patient with thyroid eye disease. The main study were done a few years ago by Wocamp. They used 15 patients randomized into one arm to use IV steroid, another arm used surgical decompression. Didn't show any major benefit between both, no major comparison between both in the form. So immediate surgery didn't show any better outcome compared to IV steroids. The new emerging treatment, lots of things on the pipeline, lots of difficult names to pronounce. The main modalities, I thought I'll just put the modalities on. There are medications that target orbital fibroblasts. You remember the orbital fibroblasts that we put on the pathophysiology slide. There are medications that will target TSH receptor, so they will block the TSH receptor. There are some medications that will have dual blockage on the TSH receptor and IGF-1. There are medications that will target component of inflammatory cascade. There are T cells, medication that will target T cells, and medication that will target B cells. Belimumab is a non-medication that is used for lupus already. They are all in phase 2 and 3. The question always, we face cases where we need to use radioactive iodine, especially when a patient has thyroid eye disease. The use of steroid pre and post treating these patients in a form of low dose, 0.5 milligram per kg per day, up to 2 months post-treatment is very effective. We didn't have any flare-up in our clinic when we use steroids. Obviously, if there are no contraindication to the use of steroids.
Dr. Ahmed, you have only 3 minutes left. Huh?
In conclusion, early recognition is very important. As you could see on Randall's curve, we will reduce the chronic long-term changes. The early recognition is also should be combined with the close monitoring of the thyroid eye disease, because remember, the mild thyroid eye disease could go and move to more moderate or severe thyroid eye disease. The improving therapeutic option is not easy. The pathophysiology is not easy. The cost of a new treatment is really high, but it is all promising. But remember, the good old steroids still work, and there is very good evidence that it works very good. And thank you very much.
Thank you very much, Dr. Ahmed, for such a splendid talk. And thank you very much for finishing on time.
Thank you.
I think we are moving nicely in such a very fantastic session today in the thyroid and adult endocrine setup. It gives me special pleasure to welcome our next esteemed speaker, Professor Naifa Busaidi, and I welcome her actually on your behalf to her homeland. Professor Naifa Busaidi is currently professor at the MD Anderson Endocrine Center. She trained actually in Baylor College of Medicine in Texas, where she finished her fellowship and training and residency program before going ahead actually, and she trained further in the MD Anderson Cancer Center. And after that, she has actually joined the faculty of such actually very high profile institution. Professor Naifa is very well actually credited by being an icon actually in her field of thyroid cancer, and she will deliver a talk to us today. I think I will just pass over the platform to you, Professor Naifa. Professor.
Assalamu alaikum, everyone, and thank you for joining us this evening. It's a very nice webinar over these 3 days. It is my distinct pleasure today to be here with all of you and talk about differentiated thyroid cancer over the next half hour or so. These are my relevant financial disclosures. So today we're going to talk about differentiated thyroid cancer, and I'm going to add some draft updates. The American Thyroid Association updated their thyroid cancer guidelines as well as their thyroid nodule guidelines, which you'll hear about after this talk. But it's very much in draft form and will not be released until early mid 2025. But I have some draft that we're allowed to share with you that I will add if it's a change from the previous one. So the incidence of thyroid carcinomas was increasing worldwide and was fast growing, and it was in smaller tumors as well as larger tumors. So it was not just simply because we're doing more ultrasound now and picking them up. It's finally flattened out in the last couple of years because previously we were the fastest growing cancer. It is 5th and now dropped to the 7th most common cancer in women. So it's important that not just endocrinologists understand that, but oncologists as well as many other and primary care physicians and surgeons, because we're going to see it more and more. So when we talk about thyroid cancer, there's 4 main types of thyroid cancer, but the most common are papillary and follicular thyroid cancer. You can see the incidences on the right-hand side. And together, papillary and follicular thyroid carcinoma are going to be called differentiated thyroid cancer, which is today's talk, or DTC. A much smaller percentage, thankfully, are medullary thyroid cancer, which comes from a different cell in the thyroid known as C cells, and anaplastic thyroid cancer, which also comes from the same cell as differentiated thyroid cancer, but is thankfully much more rare. Now, when you hear talks earlier in the webinar about GLP-1 agonists, when they talk about thyroid cancer incidences and the worry from the GLP-1 agonists, they're talking about medullary thyroid cancer and not differentiated thyroid cancer. And we talk about that in the panel if somebody has a question about one of the papers that came out last year about differentiated thyroid cancer and GLP-1. So thankfully, even though the incidence of thyroid cancer was increasing recently, the deaths are fairly stable. So when we talk about differentiated thyroid cancer and how well or not so well people do, we use the typical tumor, nodal, and metastasis classification, or TNM classification, that other cancers use. So based on the size of the tumor, where it's located, where the lymph nodes are involved or located in metastasis. But this is the only cancer, differentiated thyroid cancer is the only cancer where we use age in staging, okay? So patients under the age of 55 or versus 55 and older. And so if you're 55 or less, you have stage 1, no metastases, stage 2, yes metastases. So age matters in thyroid cancer. We don't know the etiology of over 90% of differentiated thyroid cancers. 10% of the time it's associated with an exposure to radiation, especially papillary thyroid cancer. And when we talk about radiation, we're not talking about dental x-rays. It's something where they had a treatment for another cancer when they were younger, about 5 to 20 years earlier. And less than 5% is it familial. Patients will always worry, are my children going to get this? Well, less than 5% of the time it's familial, and we don't have a gene to test for it. So when we think about syndromes and genetic disorders associated with thyroid cancer, the top two are what we typically think about. So Cowden syndrome and familial adenomatous polyposis, or what used to be known as Gardner syndrome. The multiple endocrine neoplasia that we hear about is associated with, again, medullary thyroid cancer and not differentiated thyroid cancer. So we don't think about that with the GLP-1 agonists. Okay, so the standard therapies for differentiated thyroid cancers are three-pronged. Surgery is the mainstay of treatment. Radioactive iodine is the second treatment to prevent recurrences. And then sometimes we have to go back and do more surgery and more radioactive iodine. And then the third component of this is suppressing the TSH, which is a form of anti-cancer therapy. The surgical treatment is the most important. It's the best chance at getting rid of the disease. And the key is to find a surgeon who knows about thyroid cancer and not just thyroids in general. And, nowadays we've moved to less is more. So smaller tumors, you just do half a thyroid or lobectomy. And the larger tumors or lymph nodes involved, you do a total thyroidectomy, remove the whole thyroid. And when we think about neck dissections, we don't do prophylactic neck dissections for differentiated thyroid cancer, which is different from medullary. We do a central neck dissection if there's clinically apparent nodes or advanced disease, like T3 or T4, so larger tumors that are more invasive, or if you have lateral nodes, what's called N1B. You do a lateral neck dissection only with clinically apparent disease, and we do not currently use molecular testing to determine the extent of surgery, okay? So when it comes to radioactive iodine, which is the second treatment, right? So after you've had good surgery, the goals of radioactive iodine are to decrease recurrence and decrease the risk of death. But most thyroid cancer patients are at low risk for recurrence or death. So the question had come about, do we continue to do radioactive iodine in these patients? And physicians also said that, well, it makes our job easier for follow-up because the cancer marker thyroglobulin can be used if we use radioactive iodine. But thankfully, ultrasound has gotten better and its ability to detect disease is underestimated. So, and given that radioactive iodine has a slew of side effects, even though it's very well tolerated in the majority of patients, if you're the one who has the side effects, it's 100%, right? So given that it has side effects and we have other ways to detect disease, the conclusion in the guidelines was that less radioactive iodine is better. There's still a role for it, but let's look at what its role is. So in the 2016 guidelines, they have this page for radioactive iodine that looks at the risk of structural disease recurrence. Patients are either at low risk for recurrence, intermediate risk, or high risk, okay? And this went by size of the tumor, whether there's lymph nodes involved, was it follicular or papillary thyroid cancer, and then it added a percentage of recurrence based on mutations as well. The goal here was that the patients at low risk for recurrence, we do not recommend routinely radioactive iodine. Those who are at high risk for recurrence, we do recommend treating with radioactive iodine. But those in the intermediate, which is a lot of patients, we said consider. It's a discussion with the patient. So what the new guidelines is, I don't expect you to read this slide. This is a draft recommendation from the recommendations that are expected to come out in 2025. And they divided it into papillary on the left, follicular in the middle, and oncocytic thyroid cancer, what used to be known as Hürthle cell thyroid cancer. And you'll see they have 4 tiers here. So the low risk is still at the bottom. And then they divided intermediate into low, intermediate, and high intermediate. And then high risk, which was greater than 30% chance of recurrence. Okay, so there's a little more granularity to the new guidelines. And again, I don't expect you to read this because they haven't come out, so we don't want to assume that it's how the final is going to be. This is a slide just to remind everybody that radioactive iodine has a role in patients with high-risk disease, those over 55 with stage 3-4 disease. Radioactive iodine is associated with improved overall survival, so it does save lives. So we don't want to just throw radioactive iodine away. And for those who aren't necessarily familiar, looking at radioactive iodine scans, this is a head shot. You can see the head here and the shoulders. This is anterior and posterior thyroid bed uptake, nasopharyngeal uptake, and this is posterior. See how it's lighter than on the anterior. And we tend to do the whole body scan. Okay, so you can see the outline of a human here, and the black is the uptake of iodine here. This patient has lung metastases that take up iodine as well as some neck disease. So after surgery and radioactive iodine, the third treatment is thyroid hormone suppression. And the goal is to give the patient, let's say you've done a total thyroidectomy, to give the patient's thyroid hormone and give them a little more than their body needs to keep the TSH suppressed. We do this by giving the patient 2.1 micrograms per kilo. And we have to remember that this is almost as good as chemotherapy. It keeps the TSH suppressed. It's a form of anti-cancer treatment. But the guidelines that came out in 2016, which are the only guidelines or the last guidelines that we have right now, at least from the American Thyroid Association, as well as partially the European Thyroid Association, stage 1 or low risk, the TSH goal was 0.5 to 2, so the upper end of normal or lower end of the TSH. And the intermediate to high risk, we'd keep the TSH at 0.1 to 0.5. And those with metastatic disease, we'd say keep the TSH less than 0.1, but not undetectable, because that just increases your risk of atrial fibrillation and bone thinning. But this slide, I put the Kaplan-Meier curve as a reminder that suppressing the TSH is associated with improved overall survival in high-risk disease. Again, TSH stage 3 and 4. Okay, so each of these prongs, we have to know that the idea is personalizing the therapy and knowing the patient that we are treating and how aggressively or non-aggressively we should treat them. And then the other thing that was more unique, at least in the 2016 guidelines, which now they've made it more granular in the 2025 upcoming guidelines, is that risk of recurrence is dynamic. So it's not just that you take the patient, look at their original stage, which is important, how many lymph nodes were involved, what the size of the tumor was, and then that predicts risk of death. But then each time you see them back, you're looking at their risk of recurrence. Okay, you reassess this constantly. Okay, where is their disease now? And there are 4 categories: excellent response to therapy, biochemical incomplete response to therapy, structural incomplete response, and indeterminate response. And that looks like a bunch of words, but they've actually defined it for us. To call somebody excellent response to therapy means that you don't have any clinical, biochemical, or structural evidence of any thyroid cancer. And then biochemical incomplete is like it sounds. You have an abnormal cancer marker called thyroglobulin, a thyroglobulin antibody, but you can't see anything on imaging. Structural incomplete means we can see disease in imaging. Those are the patients that are at highest risk for death and recurrence, or they have persistent disease. And then indeterminate response, I have some nodules present, I have a little bit of antibody, I don't know if they have disease or not. The important thing is how they broke it down, is how we think about these patients. What's their risk of this coming back or causing a problem? And as you can see, excellent response to therapy has the lowest risk of recurrence. Structural incomplete response has, because they have persistent disease, and they're at the highest risk of death, and everything in between. But everybody speaks a common language across the world was the idea. When you see a patient with thyroid cancer who came from Bangkok, if they're using these terms, we all know what that means and what their risk of disease is, and it helps us to have patients understand as well. But to say a patient does not have any evidence of disease, we need to say that the cancer marker, or the protein that we measure in the blood named thyroglobulin, which comes from normal thyroid tissue and thyroid cancer, and thyroglobulin antibodies, which 20 to 30% of thyroid cancer patients have, both of those need to be undetectable, need to be measured every time we see the patient, and we do imaging at the same time as well. So in this case, 85 to 90% of this thyroid cancer, if it comes back, comes to the neck. So you do an ultrasound of the entire neck, not just the thyroid. You look at the lateral nodes, central nodes, to say there's no disease. Now, this is, I'm sorry about the slide, this is the draft recommendations of what's potentially going to come out in American Thyroid Association in 2025. And what they've done, it's a complicated a table, but if you break it down, they've put response to therapy, those 4 categories I showed you earlier: excellent, indeterminate, biochemical incomplete, structurally incomplete. And then they've divided what was the extent of treatment. Did they have a total thyroidectomy with iodine, total thyroidectomy without iodine, or just half a thyroid out? And then the definition of excellent response to therapy would change based on which of these treatments you had, and the TSH goal would change based on what response to therapy you have. So I think it's much more granular in explaining to physicians and healthcare providers, what do we do with those patients? Rather than panicking that there's a little bit of thyroglobulin, this is what we want you to do. And then the new thing also in the draft ATA guidelines that they're going to add is what's called de-escalation of monitoring. So they're going to define monitoring as those patients you're following up who have no evidence of disease, or what's called excellent response to therapy. And they're calling active surveillance, reserving that term for patients who have disease or have thyroglobulin that's, a little bit present or detectable. So active surveillance is implying that there may be a problem. Monitoring is implying I'm following you to make sure there's no problem, if that makes sense. So if somebody has a hemithyroidectomy, you only check a thyroglobulin once, but you keep the TSH normal and you stop. This was the most important part, is the third column on the right. You stop following after 5 to 8 years, right? Because right now we're doing lifetime for everybody. And if you had a total thyroidectomy, were not given radioactive iodine, and you have an excellent response to therapy, so you have to meet all those conditions, then you only need a thyroglobulin less than 2.5, and you can stop checking after 5 to 8 years, but you always check your thyroglobulin, okay? You don't do ultrasounds, but you still check your thyroglobulin antibody. And then in those who have total thyroidectomies with iodine and excellent response to therapy, your TG needs to be lower, right? Because you've given them radioactive iodine. You see why the difference between 2.5 and 0.2, but again, you can stop following. So these are for low risk differentiated thyroid cancer with no evidence of disease, right? So it's nice, de-escalation of monitoring. So, I like Frank Lloyd Wright's quote that I saw Dr. Sosa put up once: less is more only when more is too much, right? And that's exactly what they're doing with the guidelines. So I think it's going to be very helpful. Now, what if the small percentage of time, the 5 to 15% of the time, that patients have an elevated thyroglobulin and have a recurrence? Again, most of the recurrences are in the neck. So you need to do imaging of the neck by ultrasound of the neck with or without a CT neck, depending on what's good in your institution and where you're expecting the disease to be. Second place thyroid cancer likes to go is the chest, so you do CT chest. And then you can at least one time look at a radioactive iodine scan to see if there's any uptake in that radioactive iodine. If there's any radioactive iodine uptake. And then in the rare patients who have metastatic disease, you can do imaging of other body parts. But it's not like other cancers where you do pan imaging. You start with the neck and chest. The role of PET-CT is different in differentiated thyroid cancer than it is in other cancers. Not all thyroid cancers, thankfully, have FDG avidity, okay? Or that sugar uptake is what FDG avidity is. The more aggressive differentiated thyroid cancers, or the more metabolically active differentiated thyroid cancers, have FDG avidity. So in general, the guidelines suggest that PET-CTs are most helpful if the thyroglobulin is higher than 10, or the histology was poorly differentiated, and other imaging is negative, and you want to see where's that thyroglobulin coming from. There was a study many years ago that Memorial Sloan Kettering did that showed that tumors that have FDG avidity patients is associated with lower survival. And the more lesions they had, the worse the survival. So PET can be prognostic and predictive of lack of radioactive iodine uptake. Okay, so when we talk about metastatic disease, again, this is a small part of the pie, but 15 to 20% of thyroid cancers will recur. Most of them will be in the neck. And if one has small volume, non-progressive disease, it's just sitting there, it's not growing, you can do observation with TSH suppression and continue to do imaging. But if you have disease that's growing or in potentially threatening areas, then this should be surgically resected. So you want to have a close relationship with your surgeon. Most of the recurrent neck disease does not take up iodine. You're allowed by the guidelines to give 1 postoperative empiric dose, and if it's negative with a positive TG, you close the door to iodine for the rest of their life unless you're doing what's called redifferentiation. And unfortunately, people keep giving radioactive iodine because for a long time that's all they had in their toolbox, and we no longer do it. So when we talk about metastatic disease, remember that metastatic disease is associated with poorer survival, but progression is actually what determines that. And if their tumors do not take up iodine, shown here in this red curve, their overall survival is lower than those who have distant metastases that do take up iodine. So if we take all the differentiated thyroid cancer cases, about a third of the time, the patients will have recurrent disease. So again, the vast majority of them do well. 10% of the time, they'll have metastatic disease. And about 5% of the time that they'll have radioactive iodine-resistant differentiated thyroid cancer. Now, just because I show this pie to say that metastatic disease is rare, however, it does not mean you tell the patient, if you had to have cancer, this is the best cancer to have. I can't tell you how many patients have heard that from their physicians, whether they're primary care, endocrinologists, or oncologists, and they come crying now because they need chemo, and they were told to, in their minds, they heard, this is the best cancer you can have, so you don't need follow-up, right? So don't tell, there's no good cancer. We should not tell patients that. So how do we treat patients with radioactive iodine negative metastases? Well, again, this is the guidelines, which is not going to change much in 2025, that if patients have thyroid cancer that's refractory or resistant to radioactive iodine and is not surgically resectable, but if the patient's not symptomatic from it, it's stable and not growing, you can just do TSH suppression, but follow them up with imaging and labs, okay? So we do need every 3 to 12 months imaging. And I recommend you do that shorter time, right, initially, and then you can spread it out. And then if they do have progressive disease, then you can talk about systemic therapy. So they're refractory to iodine, so you're saying no to iodine, but now you are looking at kinase inhibitors. I'm going to quickly show you, at least in the United States and actually in several parts of the Gulf, where the drugs that you can get. And so we need to figure out who are the best patients that one can treat, right? And who do we not? And so if you look at this graph, the radioactive iodine responsive thyroid cancer, those patients make it to their end of their goal line or their lifespan. And those patients who have radioactive iodine refractory thyroid cancer, some make it to what their lifespan would have been, but radioactive iodine refractory disease shortens it in some, and we still don't understand that difference. Cytotoxic chemotherapy that you think about with other cancers in general does not work in thyroid cancer, or it's short-lived. But doxorubicin is FDA approved for that indication. Targeted therapies are more specific to cancer cells, and they don't just quickly divide up rapidly growing cells, but they are less harm to normal cells, and that's why they're being used much more often. The vast majority of papillary thyroid cancers have, you look at the mutations in the cell, they have a BRAF or a RAS mutation. So there were a lot of drugs being put there, but there's a small percentage that has a RET or an NTRK, and I'll show you why that's important. But they have a lot of blood flow, a lot of VEGF. So a lot of the drugs initially were directed at anti-VEGF therapies. So now the multi-kinase inhibitors or anti-VEGF drugs that are FDA approved in the United States for advanced thyroid cancer that's progressing and cannot be resectable or treated with iodine include sorafenib and lenvatinib. But you can use and cabozantinib. You can use vandetanib, but it is only approved for medullary thyroid cancer. There's other drugs that work in thyroid cancer as well. And then, what actually got the labeling, sorafenib and lenvatinib got first-line therapy, and cabozantinib got second-line therapy. But the FDA approved drugs in what's called a tissue-agnostic manner, okay? So what that means is any tumor, solid tumor that traditional therapies are not working on, if they have this abnormal gene or protein on the cancer, so again, personalizing your therapy to cancer, you can use these drugs. So NTRK inhibitors, there's 2, RET inhibitors, there's 2, and if the patient has a tumor that's microsatellite unstable, they can use immunotherapy called pembrolizumab. So there's a slew of drugs. I don't expect you to memorize it, but I just wanted to show you that it's advanced a lot over the last 10 years or so. And BRAF inhibitors are drugs that are often used in BRAF mutant thyroid cancer because it's one of the most common mutations in papillary thyroid cancer. So you'll see those being used more and more, just like in melanoma. What about tumors that are resistant to radioactive iodine? Can we use these drugs to make it sensitive to iodine again? And this concept has been looked at with many, many drugs, but probably one of the more successful was called selumetinib. This is only FDA approved for gliomas and pediatric tumors, but it was looked at in thyroid cancer, and they could successfully take up iodine. And then several investigators had looked at BRAF inhibitors for BRAF mutant tumors, and it can now restore the iodine uptake. But unfortunately, they're not cured still. So there's still a lot of research as to what's the role of redifferentiation, which means making the tumor sensitive to radioactive iodine. And we don't want to forget, if you have specific metastases in bone or in the spine or brain, that we want to do surgery or radiation to those areas, and bone modifying agents. So these are all still tools that we have for thyroid cancer, and you can do local therapies. The role of immunotherapy in differentiated thyroid cancer is undergoing a lot of research, and so we're using it in combination with the targeted therapies, but I can't tell you, there's no label and indication that I can tell you about. Just to remember that, look for clinical trials. A lot of, there's a couple of organizations that are international thyroid organizations, and they have representatives in the Gulf. And so you want to talk to, your thyroid cancer specialists in the Gulf, or email me to find if there's clinical trials in your area. And so I just wanted to thank everybody that this takes a whole team to make this work. And anytime you're seeing patients with thyroid cancer, you don't want to see them in a vacuum. So whether you're a primary care physician, surgeon, endocrinologist, oncologist, you want to make sure that you take everybody's opinion into account and talk to people and refer patients to where they'll get the appropriate care. So with that, I want to thank the Gulf Association for inviting me today, and it's been my honor, and I'll be available for questions later. Thank you so much.
Thank you very much, Naifa, for such a very fantastic presentation. We'll move to the next speaker. And before going ahead and introducing my friend and colleague, Dr. Ali Khalil, I would like just to thank Merck for providing the platform and the appropriate, logistics for such a wonderful series of webinars. They have been very supportive, and would like, on behalf of GATE and on behalf of the endocrine community, to thank them for such generosity in supporting our educational endeavors. I would like also to highlight that this meeting is credited by 1.5 CME points and credits, and this actually will be posted to all participants. And I would like also to remind all our respected delegates just to remember to scan their QR code at the end of the meeting when we finished everything, in order to send their feedback, because this is very important, and it helps us actually to plan future meetings. Now we'll move into the other side of the spectrum, and again, it gives me special pleasure and privilege actually to welcome Dr. Ali Khalil. Ali Khalil, who is consultant endocrinologist currently at the Reem Hospital in Abu Dhabi, and Ali qualified actually from Marseille in France, and then he moved across the Atlantic to Toronto, where he trained actually in internal medicine as well as in clinical endocrinology. Following that, he moved actually to the Gulf, where actually he was one of the pioneers actually in working as an endocrinologist for several decades at Sheikh Khalifa Medical City, and he has established quite excellent platform for service as well as for education. He moved later on to the Imperial College London in Abu Dhabi, where he also actually made an excellent contribution before his current tenure at the Reem Hospital. Ali is a veteran. He's very well credited by being one of the key figures in the endocrinology circle in the Gulf, and he has actually served as a past president of the forerunner of our organization. He actually was a past president of the AA's Gulf chapter before it actually metamorphosed into the Gulf Association of Endocrinology and Diabetes. Ali is going to handle the other side of the spectrum by giving us a talk about thyroid nodule, an area very close to his heart, where he has been practicing, has been making excellent contribution. Ali, the platform is yours.
Thank you very much, Dr. Tariq, and congratulations for your new position as President-elect for GATE. And thanks for the organizer for asking me to be part of the speakers for tonight. Okay. So the first, what I was asked to do is to give you an update of where we heading in the management of thyroid nodule. So my objective for tonight is to highlight the importance of ultrasound risk stratification if you're facing a newly diagnosed thyroid nodule, and to finally to elaborate on the recent drafted ATA thyroid ultrasound reporting thyroid system. Let me say I have no financial disclosure to make. And let me remind you that thyroid nodules are becoming really quite prevalent. This study goes back to 1993 by the late Mazafari, indicating that initially using palpation, the prevalence of thyroid nodule was not exceeding 10%. And now with the advent of ultrasound and with advanced age, the prevalence could reach 50 to 60%. So this is becoming a very common topic. And but the point to make here is that 95% of thyroid nodules are benign. So our focus in the remaining 5 to 10% is to identify those who have underlying malignancy. And this is really where a lot of effort has been made to risk stratify patients presenting with thyroid nodules. And obviously, the risk stratification could involve clinical, biochemical, ultrasound, cytopathological, molecular, all aiming to minimize the amount of harm that we could do for the patient if the patient have evidence of benign nodules, and to focus our work on those who show high-risk features and needs more attention. When we talk about management of thyroid nodule, we cannot really escape not talking about ultrasound of the neck. This is an essential element in providing proper risk stratification. And that's why many international societies have worked together to provide some kind of lexicon that makes it easier for pathologists, radiologists, endocrinologists, all to focus their effort and risk stratifying their patient in an effective and practical way. And as you see, we have one of the commonly used guidelines for the management of thyroid nodules, the American Thyroid Association, that came up with 5-tier system in risk stratifying patient. The ACE minimized it, made it more practical, 3-tier system. And there's the ACR, the American Radiology, College of Radiology in US, the European one, the Asian one, like the South Korean, all really aiming to the same target, is optimizing management and risk stratification of thyroid nodules. Now, all those guidelines could be divided into 2 main pathways. One that really focused on pattern recognition, like the American Thyroid Association, which means that they identified a series of ultrasound pictures, and they ask you, once you have done your ultrasound, to match your ultrasound picture with one of those in their ultrasound reported system to see whether you're dealing with a very low risk, intermediate risk, or high risk. And the other group, which is pioneered mainly by the ACR thyroid system, they are using a point system, which means that they look at specific ultrasound features and they assign a point system for each ultrasound feature they identify. and they sum it, and they also subgroup them into what we call really risk stratification. And I'll start with the ACRR thyroid system to show you, and this is the one I use most commonly, that came into in practice in 2017. What they do is they look at different features of the thyroid nodule, mainly composition, echogenicity, shape, margin, the presence or absence of calcification, and they try to assign numbers to each ultrasound feature. So, for instance, in this nodule, as you could see, we're dealing with for those who do ultrasound, they know what I'm talking about, with a solid nodule, mainly hypoechoic. The margins are really very clear margins. There is no intranodular calcification. So if we talk about composition, so it's a solid, so they go to solid, and solid is assigned 2 points, okay? And if we look at echogenicity, is hypoechoic, which means that it's darker than the remaining thyroid tissue. And it's assigned 2 points. So 2 points and 2 points, let's make it 4. It's wider than taller, so 0 point. The margins are appropriate, so another 0 point. No calcification, 0 point. So the total is 4 points. 4 points that takes you to the category thyroid 4, which is between a group with 4 to 6 points. The risk in this group is having underlying malignancy is 60 to 75%. So we're heading to the high risk group. And the indication for you to do a biopsy is if your tumor is more or equal to 1.5 centimeters. I advise if it's between 1 and 1.5 to advise follow-up on the patient. This then this was preceded before by the ATA. The ATA, which was initial publication, the initial publication was in 2015. And this was, as I mentioned, based on pattern recognition. It means, like, if you look at the beauty and the beast, if you like the beauty, you're a very low risk. So you match your picture with the lower risk group, and you're like the beast, so you have a picture that's more consistent with the pattern, consistent with the high suspicion nodule, like hypoechoic, presence of calcification, ill-defined margins, and some really extending into the strap muscle anteriorly, or having detectable suspicious lymph nodes. Now, as you see in the ATA, the advice for doing FNA in 2015 was quite a little bit aggressive, in the sense that once you reach to 1 centimeter level in the higher intermediate risk group, you have to do biopsy. 1.5 centimeter for low suspicion, and 2 centimeter for those with very low suspicion. And this has brought some criticism that maybe ATA was a little bit detecting a little bit more false positive cases, but very highly sensitive. So which one to pick up among all those guidelines? It's basically, it was clear up till recently that no single reporting system has universal acceptance, and that's why we see too many of them. But ATA, the good thing about it, it provides easy pattern recognition. It thyroids maybe is more accurate and avoid unnecessary FNA, because their target and limit for doing biopsy is higher than the one put through the ATA guidelines, and that lymph node were only included in the ATA, not in the thyroid. So none of them really give you a complete guidelines that will be complete by itself, because most of them are still operator dependent. There is diversity in the way operator interpret ultrasound features, and that really can affect the appropriate risk estimation. But in any event, there was one nice study where I looked at modifying the size of the nodule where the biopsy is performed. So if you adopt the one adopted by the ACR, all those guidelines have almost the same accuracy and sensitivity. So, so this is one of the reasons the ATA felt that there's some more work that needs to be done. And specifically that some criticism was made for a very commonly at that point useful practical guideline to follow, is that you have a group of images that you cannot put them in use them in the ATA reporting system. And this is based on a nice systematic review by Kwan, published 1 year back in Thyroid, where they look at 16 randomized studies and including 21, close to 21,000 nodules. And they identified that there is probably around 7% of the thyroid nodule are non-classifiable if one tries to use the ATA 2015 reporting system. And if we pool the risk of malignancy into this group, 7% group, actually you reach it's around 20.3%. So it's a little bit higher, especially when we realize that most of those non-classified fall in the low risk and intermediate risk ATA group. The only difference here is that if you use, those are a group of pictures where if you add one of those suspicious features, like either look at the margins, and if you have irregular margins, or you have the nodule is taller than wider, or there is presence of punctate echogenic foci or microcalcification, is one or more are added, for instance, to a hyperechoic nodule, which in the 2015 ATX classified as low risk, that will put it at actually higher risk. And this is for reason the ATA felt that some work that needs to be done to bridge the gap between what was missing in their initial reporting system. So they came up with a draft, actually, that was presented at the ATA meeting in Chicago in October 2024. And their aim was to ensure that all nodules can be classified and to provide updated estimated figure for the risk of malignancy based on the current literature. And to do so, they introduce something new, what they call it a user-friendly algorithm approach to stratify nodule, would make it a little bit practical, that you will have online application so you can download it on your phone and use it whenever it's needed. So that was the purpose of the ADA now draft that really they presented in Chicago. And I will highlight some of the things that came up with. It's I have to mention it's still a draft, so it will be published, as Dr. Naifa was mentioned, will probably be published in 2025. So nothing really is that you could trace down at this point. So this is basically the same. They kept the same reporting system that they have 2015, but they added all those figures that they felt were absent with those 7% non-calcifying nodules. And it happens that most of those they fall into the low suspicion and intermediate group. Looking at this, only few in the high suspicion, and the high suspicion is the one where you have a calcification where with the tissue protrusion, or you have features which suggestive for cystic papillary carcinoma. Whereas the other forms, where the margins were lobulated, where there's a presence of calcification, where the echogenicity is mixed between two patterns, or there's presence of a group of macrocalcification. All those really were included and modified and modified also the risk of malignancy. So if you look like side by side to look at the risk of malignancy, if you look at the 2015 figures that they had, you look at the risk is not continuous. Like you have from less 3%, you move to 5 to 10%, and then between 20% to 50%, there is a gap. So they felt, no, we need to make it a little bit more continuous. And if you look in the 2025, and they moved from the risk in the benign group from less than 1% to less than 3% in very low suspicious group, 3 to 20% in the low suspicion, and 20 to 50% in the intermediate suspicion, and more than 50% in the high suspicion. So there is continuity in the risk. So it's a continuum of risk, not the same as the two before being dichotomous. Now, also, they tried to rejoin the ACR thyroids by being a little bit more strict on the limit for doing your biopsy. So if you see in the high suspicious intermediate group for 1 centimeter, they advise you to do biopsy. Now they estimate, no, we have to consider that will make the number of biopsy done a little higher than really what it should be. And to avoid this inappropriate biopsy, they increase the size. And as I mentioned, they felt this really will add more accuracy and less false positive. So 1.5 now is for the high group, and they gave you a range, 1 to 1.5. The lower range where similar to what they had before. If you have other factors that maybe make the risk of malignancy higher, like if there's a family history of thyroid cancer, if there is maybe on the PET scan, it light up with SUV being at a high level, if you have local symptoms. So those, they felt young age, they felt those maybe will push you to use the lower limit for biopsy rather than using the upper limit of 1.5. And in the very low suspicious and benign, they felt no FNA is needed, whereas the biopsy threshold will be like 2 centimeter for the intermediate risk, and then 2 centimeter for the 2.5 centimeter for the low suspicion. And to make it easy for the practicing physician, they came up again this is a drafted algorithm where they felt that to make it easy on the practicing physician, they came up with this algorithm that is based on mainly on composition of the nodule, whether it's solid, cystic, or non-classifiable. Now, solid, it has to be like more than 90% solid, cystic defined, and more than 10% cystic. And within the solid, they subclassified on markedly hypoechoic, like similar to the echogenicity from staph muscle, to hypoechoic, to hyzoechoic or hyperechoic. For instance, if I take this nodule, which is obviously it's a solid nodule, and It has a minimal cystic component, but we go by the dominant echogenicity, which is hyperechoic. So it's solid hyperechoic. That will take you in the algorithm to the highlighted box, and that will take you down if there are no additional calcification or regular margins or other those what they call special feature, to a low suspicion nodule. And within that range, the risk of malignancy at 3 to 20%. And the indication for biopsy they give you is between 1.5 to 2.5%. So this is really the most of the new things that you will see in their updated algorithm and reporting system, which I think will add some value. The group has worked really hardly to come up with this, but I think personally everyone should get used to a system that where the person is become expert in using that system. We are left also with again with the that any ultrasound figure that you will see is operator dependent. Is there still a place to make improvement? Is artificial intelligence could be of value to make it easier to harmonize all those reporting system? It will be. Some systems are very active. Actually, you have now some ultrasound machines where software is incorporated in their ultrasound, and where they can identify and help you identify and risk justify thyroid nodule for you. And some studies have already been done in this regard. It's one of them showing that it obviously, definitely, it will improve the inter-observer agreement and probably the reporting system in overall in those cases. Having said this, I'm coming to the end of my presentation. We have to always remember that any decision, any risk stratification and figure that we come up with should be incorporated based on the information obtained from the clinical and other means that will help risk stratifying the patient being at the end, the key element, and to discuss all this and to put it in a way that will give you the most appropriate way to manage your patient. And with this, I'll stop at this stage. Thank you very much.
Thank you very much, Dr. Ali. I think we will move to the final session tonight, and I would like to welcome to the center stage Professor Maher Jallow. Professor Maher is very well known actually in the endocrine circle in the Gulf. He's a very respected figure in the academic circle. He's currently clinical professor in Ajman University and the Gulf University Medical College. He's going to give us a talk tonight about the art of precision achieving a steady euthyroid state. Professor Maher.
Yes. Good evening, our colleague. Thank you, the chairperson and the amazing panelists. And we need to thank the Gulf Association for Diabetes and Endocrinology for this very important update on the thyroid disease. I will cover in 20 minutes the precision in hypothyroidism management towards achieving a steady euthyroid state. This is Gulf Medical University and Zombie. This is my disclosure. And they have one, objective for today towards achieving a steady euthyroid state with consistent and precise treatment, focusing on the new formulation euthyrox, a new formulation. We know that consistent and precise treatment for patients with thyroid is very important. And sometimes raised before that levothyroxine sodium may be regarded by some as a neurotherapeutic drug. Patient thyroid level must be carefully monitored to avoid the long-term under or over treatment. And we know that the long-term under or over treatment and the TSH not on target can be translated into many comorbidity in the cardiovascular disease, dysrhythmia, as well as bone health, both the hypo and hyper. So we need a precise TSH with the replacement therapy. Yes, and we know that levothyroxine preparation, despite carry the same dose, but have sometimes different bioavailability. Many factors can influence the thyroxine absorption and availability in the body. And there is variation in the thyroxine content among the various approved preparation with the same stated dose on the tablet, in some cases greater than 10%. This is a potential problem if a patient switch thyroxine preparation. So even a slight change in levothyroxine dose can alter the TSH level and adversely affect the cardiac and the brain function, among other things. And clearly, you know that the American Thyroid Association guidelines answer to the question, is there a clinical rationale for prescribing a brand name levothyroxine preparation in a preference to generic levothyroxine? And the recommendation is clear that prescription of a brand name levothyroxine or alternatively maintenance of the same generic preparation, it means maintenance of an identifiable formulation of levothyroxine, is advised. Switches between levothyroxine products could be potentially result in variation in the administration dose and should generally be avoided for that reason. With strong recommendation for the frail patient, high-risk thyroid cancer patient, a pregnant patient, and also strong recommendation with moderate quality for early childhood hypothyroidism. So the development of the new formulation, we will focus what changed in the new formulation. You know, there is a call in some country because of this narrow-therapeutic index that the tightened potency specification has led to the development of the new formulation of Euthyrox. Local health authority in many countries, the US, France, and the UK, have requested a tighten the potency in a range of 90%. Now, the aim of this updated specification is to ensure that the patient receives the appropriate level of medication each time. And this is important to best treat the thyroid disorders of those patients. And with this, the active ingredient is remain the same, but there is some excipient of the Euthyrox formulation have been changed to meet the tire specification and to keep the medication more steady. The bioavailability to the old formulation is remain the same. So Euthyrox, a new formulation, is bioequivalent to the old formulation with similar tolerability. You can see in the curve, it has shown to be well tolerated and has very similar safety pattern compared to the old formulation. So bioequivalent safety, the concentration time of profile for Euthyrox in new formulation versus old formulation is not different. And there is no, additional, side effect. Headache probably was one of the most drug-related treatment emergent adverse event, but usually this is not a complaint with most of our patients. So this meeting, the stringent bioequivalent criteria for a neurotherapeutic index drug is very important. And this is reassurance when our patient is switched from to the new formulation formula. So what is the change in the excipient for the dose? That the change is included that the new formulation of Euthyrox contain mannitol instead of the lactose monohydrate to enhance the product stability. And in addition, anhydrous citric acid has been added to enhance the stability of levothyroxine over time. So otherwise, the composition and active ingredient of the active molecule, levothyroxine sodium, remain the same. It is suitable for a wide range of our patients, especially when we need really a precise dose every time, for the elderly or frail patient, for the pregnant woman, for the pediatric patient, and those with thyroid cancer when the TSH level, maintenance is mandatory. Same benefit as the old formulation, and this will include that patient can take euthyroxine new formulation under the same condition as the old formulation, have the same appearance as the old formulation, and also has once daily dose regimen with the euthyroxine new formulation, offer the same broad range of strength, that from 25 to 150, so it is easy to adjust the dose accordingly. And usually, if we don't find any issue or complaint of our patient, switch to the new formulation. So it takes control of your patient. New formulation, that patients have the same over the same condition, meet the tightened potency specification for the 95-105 specification, which is mandated by some authority, and this is throughout the whole shelf life of the molecule, which is 3 years. And despite change to the formulation, the patient can continue their treatment as usual, while enabling the physician to provide more precise prescription, and the new formulation help to minimize the risk of adverse clinical outcome associated with suboptimally controlled hormone level. So how to achieve an euthyroid state in general, for our patient? It is very important to achieve a precise euthyroidism to a specific group of our patient: the children, the elderly, patient with thyroid cancer, pregnant woman, and when there is history of difficulty to reach a TSH level. And euthyroid state should be individualized. The target TSH based on a number of factors: the age of the patient, the cause of hypothyroidism, other associated comorbidity, other medication, food, pregnancy, and cancer. And the aim is to balance the biochemistry with symptoms. We use the standard high-quality levothyroxine products, and the switching between brands or branded to generic may impact the TSH, and there is variation in the levothyroxine dose between approved preparation with the others, may be ranged up to 10%. And there is some, recommendation that when probably the branded, if it is not available and you need obliged to switch, you should recheck the TSH again after 6 to 8 weeks, because probably you need to adjust the dose. Combination therapy is difficult to monitor, but aim to avoid the suppressed TSH. Sometimes we have problem how to differentiate between, patient, which is, not responding, the patient not adherence. So I think I will take probably 1 or 2 minutes to cover on the levothyroxine absorption test, which is really not done frequently, but probably it is nice to know how this can help our patient to see why the TSH not achieving the target. First of all, we need to exclude the causes of under-treatment other than this is, before the test, than other adherence issue, and ensure that no contraindication to the high levothyroxine dose exists. For example, we need to check the ECG of the patient. In the day of the test, the patient has fasted from midnight and empty the bladder immediately before dosing of the thyroxine to ensure the monitoring is possible for 60 minutes after administration. And usually we administer the equivalent of 1 week dose of levothyroxine in liquid form. It is preferred, or tablet form followed by 200 ml of water. Then observe the patient for 60-minute fasting and collect the blood sample for the measurement of the TSH, free T3, and free T4 at 0 time, 30 minutes, 45 minutes, 60, 90, 120, 240, and 360 minutes. And after the test, continue the weekly supervised administration of the same dose of thyroxine for 5 weeks and 60-minute observation, collect the sample and check. And with this, we can end with that inadequate free thyroxine rise after administration of levothyroxine. It needs further investigation of the malabsorption issue. The TSH normalized due to non-adherence. So this we need to consider other options, including probably the weekly dosing instead of daily dosing, or liquid formulation, and also ingestion at bedtime, or consistent rise in the free thyroxine without rise in the TSH, and this is considered the dose adjustment or disorders of the thyroid hormone metabolism. So the Thyrox new formulation, this is help to address the new regulatory specification for levothyroxine product, and the fluctuation in the daily dose of 10 to 20% may be clinically significant, especially in the most vulnerable patient. This can be avoided with this new formulation. The tighter content specification over the shelf life, which is usually around the 3 years, and the new formulation is needed to ensure the patient receive a more precise level of medication required to treat their thyroid disorder. The objective is to improve pharmacological stability, and this will go with the regulatory adherence, and also to ensure the potency specification over the shelf life of at least 18 months, but usually it is up to 3 years. And the decision of the authority is also maintained with this. Regulator have identified levothyroxine as a narrow therapeutic index drug subject to more stringent regulation compared with other drugs in terms of the accuracy and the stability of the amount of the active drug in each tablet and the level they want, and its bioavailability geometric, the mean ratio, which should be 90% confidence interval between 90 and 110, including the 100%. The new formulation enhances stability and shelf life and has enhanced product stability over time compared to the current formulation. The new formulation over 100 weeks, and also has shelf life of 36 months in all clinical zone, the temperate, the subtropical, possible high humidity, including our region in the Gulf as well. So the composition, a new formulation, the active ingredient, you have all the strength, 25 to 150, the shelf life of 3 years, protected from the light, store in package, and the change that the patent of protected formulation with improved stability, we change, the mannitol instead of lactose expedient replaced with mannitol, and anhydrous citric acid added to keep more stability. Efficacy result, the same, concentration as well as formulation. And to end that, bioequivalent with tightened specification, dose administered is always within the range of the old formulation. No TSH test required upon switching, and the switching from old formulation to the new formulation is straightforward. How should levothyroxine in general should be taken on empty stomach at least 1 hour before the meal, usually the breakfast, and we should space at least 4 hours between taking the Thyrox as well as the other medication. We know that the list of medication interfere, calcium supplement, PPI, sulfate, and bile acid sequestrant, bisphosphonate, ferrous sulfate, and anticonvulsant, and aluminum-containing antacid. Contraindication in general, it should be noted. This is, how it is taken, and the drug interaction with the other should be spaced at least 4 hours. Next. And the contraindication that hypersensitivity to the active substance, like any medication, untreated adrenal insufficiency, untreated pituitary insufficiency, untreated thyrotoxicosis. Treatment with euthyrox must not be initiated in acute myocardial infarction, acute myocarditis, or acute pancreatitis. Combination therapy of levothyroxine and the antithyroid agent for hyperthyroidism is not indicated during a pregnancy. And with the precaution during a pregnancy and lactation, treatment with levothyroxine should be given consistently during a pregnancy and breastfeeding in particular. The dose requirement may even need to be increased during a pregnancy. Experience has shown that there is no evidence of a drug-induced teratogenicity or teratotoxicity in a human as recommended by therapeutic dose level. Levothyroxine is secreted into the breast milk during lactation, but the concentration achieved at the recommended therapeutic dose level and are not sufficient to cause any development of hyperthyroidism or suppression of the TSH secretion in the infant. With this, I end my presentation and we're ready for any question. Thank you very much.
Thank you very much, Professor Jalu. And may I ask all our 4 esteemed speakers to the platform, because it is time for question and answers. Dr. Ahmed Al-Qaisi, one of the delegates, asked a question. It is rather actually long. I will read it out. Thank, we have 50-year-old female with severe Graves' eye disease, failed decompression twice, currently has severe diplopia, and her TFT is acceptable. Clinically euthyroid, mildly raised TSH receptor antibodies. Patient has no access to new immune therapy. Failed corticosteroids. What do you suggest as a sort of a remedy for her condition? Dr. Ahmed Al-Ghaisi.
Yes, thank you. We face these cases. It's thank God it's rare. It's very difficult cases. So cyclosporin, I used it before. It does work. Rituximab does work, which is, you know, you could get hold of it. It's cheaper compared to the teprotumumab or the tocilizumab. Radiotherapy, as I mentioned earlier, it does take time, 4 to 6 weeks, but, you know, nothing is working. So I would go also for radiotherapy. So these are the available options nowadays.
Thank you very much, Dr. Ahmed. Question to Professor Busaidi. GLP receptor agonist use and risk of thyroid cancer, and if screening for it is needed before the initiation of GLP receptor agonist.
Yeah, assalamu alaikum. Great questions. I think that's very timely. And there was a recent Mayo Clinic publication on that. Actually, it was an abstract form, an oral at the American Thyroid Association. So it should come out as a paper soon. So GLP-1 agonists in mice were found to be associated with C-cell hyperplasia, the precursor of medullary thyroid cancer. And so there's a black label warning to say that if somebody has medullary thyroid cancer or familial risk for medullary thyroid cancer, multiple endocrine neoplasia type 2, that they should not be prescribed GLP-1 agonists because the risk is there in animals. The risk is maybe present in humans. Remember, the animal C cells are very different from the humans, but still, that's the warning currently. Differentiated thyroid cancer and anaplastic thyroid cancer are from the follicular cells of the thyroid, which are, it's almost like the thyroid is 2 organs merged in one. So those patients are not at risk of recurrence of differentiated thyroid cancer to get GLP-1. So it's not a contraindication. In November 2023, there was a paper that came out that suggested that those patients on GLP-1 agonists may be at higher risk of developing a papillary thyroid cancer or recurrence of papillary thyroid cancer. And actually what was found, and a nicer study was done by Mayo Clinic that should come out soon, was that 2 things that are important to note. First of all, that, you know, that paper needs to be validated, and there probably is not an increased risk of differentiated thyroid cancer. So currently we are allowing all our patients with differentiated thyroid cancer or risk for differentiated thyroid cancer to get GLP-1 agonists. Two was the question that the professor had asked in terms of the risk of developing differentiated thyroid cancer. And there are studies that were suggesting if you do ultrasounds in patients who are on GLP-1 agonists, that there's an increased risk of detecting differentiated thyroid cancer and nodules. And actually what it is that's a detection bias, right? If you take all patients who are on GLP-1 agonists and do an ultrasound in them, you're going to find differentiated thyroid cancer, but you otherwise would not have done an ultrasound on those patients. So the risk is equal or equivalent to the population that it would naturally occur in. So long story short, there's no increased risk of DTC and GLP-1. There's no reason to withhold these drugs that weight loss can, remember, probably save their life, right? It's almost equivalent to gastric bypass. So just be careful. I'm not saying prescribe GLP-1s to everybody. What I'm saying is don't worry if they have differentiated thyroid cancer.
Thank you very much. It is a very common, actually, questions for especially young ladies in this part of the world who are contemplating to start GLP receptor agonist. They tend to come specifically about this because there is a sort of a bias from the private, sort of institution and some private clinics do actually market this. So thank you very much. And I think this will answer another question by the respected delegate, Dr. Abdelhamid Hamdi Ramadan. He asked a similar question in treated non-medullary thyroid cancer. Can we use GLP receptor agonists? Here we go. Professor Naif Al-Busaidi has answered the question. Okay, so this probably question can be answered by any one of you. Thyroid hormone therapy monitoring and adjustment with GLP receptor agonist treatment. Is it needed?
So
is there
I don't know exactly.
Just go ahead.
Not answering, somebody can jump in. So if people are on GLP-1 agonists and they lose weight, yes, they probably need an adjustment of their thyroid hormone, right? So we recommend at 1 to 2 months to recheck the thyroid hormone if they've lost weight, right? Not just because they're on it. If they're asking, do you need adjustment prophylactically because people are on the drugs? No. Right? Okay.
Thank you very much.
Probably this is if the patient already taking the replacement therapy. But I think for the patient who is not a patient of hypothyroidism, not taking the replacement and taking the GLP-1, there is no recommendation in recheck the TSH because he is taking, the GLP-1 therapy. Unless, of course, he got other symptoms which is suggestive of thyroid disorder.
I have to add just that most of those patients, they come really morbidly obese, and the TSH will be abnormal, like at the start, will have a little bit mildly elevated TSH. Now, is there an indication to monitor thyroid? I think it will be in the interest of really showing that TSH change when the weight comes down, that majority of those patients will normalize the TSH when they have lost significant weight. May I add actually to what Dr. Naifa has mentioned, actually there is a recent also systemic review of 35 control randomized study that looked at the effect of GLP-1 on thyroid cancer, differentiated cancer, and the overall relative risk was 1.3, non-statistically significant, and indicating also what you're saying, that really there's no risk when it comes to differentiated thyroid cancer.
Okay. Next question directed to you, Ali Khalil. Elastography has some promise on ultrasound definition of thyroid nodules a decade back. Can it be incorporated in improving the accuracy or unifying this different classifying system on ultrasound?
Actually, elastography is one of the means we used to do before. We're not using it as much because it's operating dependent and it's learning, it's a software that you have to have in your ultrasound. And you have to have the hand of really putting the proper pressure, because there are two different ways of elastography. You have the pressure one and you have the shear wave elastography. And shear wave elastography has probably more relevance than the other method. Personally, it can add, but in real practice, I'm not using it frequently unless the nodule is big And I want to have a little bit more like reassurance that it's a solid nodule, very hard, that suggests more malignancy than otherwise stated. Yeah, it could be used, but I haven't been lately using it on a regular basis. I think there is enough ultrasound criteria now that we're using that really are really quite relevant and very useful to stratify the patient.
Okay. Another question directed to you, Ali, from our esteemed colleague, Ahmed Hassoun. He says, thank you for your great presentation. What is the best cutoff? What is the best cut point percent of total to consider cystic versus solid nodule? Also, small hypoechoic versus isoechoic versus hyperechoic when we have mixed echogenicity in the same nodule. So when you have a sort of a very distinct heterogeneous nodule.
Yeah, thank you, Dr. Ahmed. When it comes from you, it's a great compliment. I have to take it. When it comes to anything that based on the 2025 draft, that they consider anything more than 10% cystic is cystic. Solid, it has to be 90%, so it's considered as solid. There is no size limit for echogenicity. Echogenicity is you comparing like the way that the waves, ultrasound waves, are reflected back to the probe. So if they are similar to the thyroid tissue, it's called isoechoic. It's if it's less reflection and darker than the remaining thyroid tissue, it's called hypoechoic. Now it's a very hypoechoic, similar to the echogenicity that you get from the strap muscles. Your strap muscles are the reference for that. They call it very hypoechoic. So for echogenicity, there's no size limit to push one way or another. Okay. Now, if you have mixed nodule, okay, the dominant echogenicity is the one that determines the type of nodule that you have. Like if you have a nodule that you have some part is isoechoic, let's say it's 20%, and 80% is hypoechoic. The hypoechoic solid nodule is the one determining the type of nodule that you have. So it will be hypoechoic solid nodule. I hope I answered this question.
Shukran, Ali. Next question again, Naifa. From Dr. Hazim Nawar. He said an elderly female, age 78, with papillary thyroid cancer, underwent total thyroidectomy with right lateral neck dissection, received radioactive iodine 150 millicurie, gamma camera, and SPECT CT showed good uptake in cervical lymph nodes, eltroxin dose 200 microgram daily. He had two questions. One, does this mean another is required based on the SPECT CT and gamma camera, or should we wait for 3 months post radioiodine dose? The second question, what is the TSH suppression target in this patient to avoid iatrogenic thyrotoxicosis, as the patient understandably so is elderly and start to feel feeling polyphagic? Thank you.
So thank you for this question. I think that there isn't a fully right answer to this. There's some leeway, but I'll tell you what I would do and what the guidelines say. So a 78-year-old patient with what's called N1B disease, meaning they had lateral lymph node, I think is what they said. Yeah, had right lateral neck dissection and was treated with radioactive iodine. And the radioactive iodine uptake scan, I don't exactly know what good uptake means. That could be a good or a bad thing. So what I mean by that is if it's, if there's a whole bunch of uptake and on your SPECT CT of your neck, you see lymph nodes that are larger than 1 or 1.5 centimeters, meaning there's gross disease left behind, radioactive iodine is not going to kill that. Okay, so it's treated and you wait and it can work for 6 to 12 months, but know that there will be residual disease. If good uptake just means that, okay, there wasn't gross disease seen, but it had some iodine uptake, that's great. That was radioactive iodine sensitive and you treated with radioactive iodine to prevent recurrence. So either way, 3 to 6, I would wait out 6 months post iodine. I would look at the thyroglobulin on the day of the radioactive iodine with TSH. Thyroglobulin should always be measured with TSH. and look at how high it is. Hopefully it wasn't too high, and reassess in 6 months with imaging of the neck and thyroglobulin TSH. I would not treat with radioactive iodine before a year. I know the Europeans treat at 6 months sometimes, but usually, the difference between multiple doses or a one high dose didn't matter in the series, or in the studies that have looked at it. And so I would wait out 6 months, re-image. You can do 3 months if you're worried about the patient, but I would not treat with iodine right now or in 3 months. The second question, TSH suppression target, I think I would probably do, there may be some people who say less than 0.1, but she's 78, and I would probably put her 0.1 to 0.5. Consider her intermediate, yeah, I would put her at 0.1 to 0.5 and see if she has symptoms, and look for those symptoms. And you can adjust, right, based on what the patient's saying. Not everybody fits the textbook.
Thank you. Right, okay. So, question to
wait, Dr. Tariq, can I add one thing? I'm so sorry.
yeah, it's fine. Yeah,
I
go
just
ahead.
wanted to say there were about 12 or 13 questions on thyroid cancer, guys, and if you can look, not to the panel, I'm talking to the audience. If you can look in the answered question, hopefully we've answered your questions. I just wanted to let people look there.
I did the same for some of them based on your request.
Same with Dr. Khalil, and I think Dr. Al-Qaisi, you all answered in the, I just wanted to let the audience know, please check that.
One delegate is asking, can the speaker share their slides with me? She put her email. It is for your sort of discretion. Right. Question, any experience with IV thyroxine preparation when there is a short time frame for optimization of thyroid status? Example, newly diagnosed localized breast CA lady with the need of urgent local excision of the tumor.
I didn't understand the question. Sorry, I didn't understand the question. Could you mind repeating the question?
Right, okay.
I think that Dr. Jallo, the question is for you in terms of, do you ever use IV? Is there any role for IV thyroxine? That's their question.
Okay.
No, I think no, unless, for example, patient with myxedema, which is not faced now, for the usual replacement therapy, usually the oral. I don't have experience, using the intravenous thyroxine with the usual patient.
Probably the case scenario wasn't complete. Probably he meant patient has got quite severe untreated hypothyroidism and she's going for a local excision of breast CA. Right. Question, anybody, can Hashimoto lead to infertility?
Wait, Dr. Khalil wanted to add something about the IV, just to clarify.
I think,
Dr. Khalil, sorry.
Yeah, no, I think the commonly given sometimes if orally cannot be taken through NG tube, like in case of patient in ICU, we have used it sometimes rectally, and it can work. But intravenously, there have been some reports that for T3, not T4, but really this is very rarely used.
Yes, we used to give it through the nasogastric tube for long-term patient, which is in our hospital. But this is considered the oral formulation. In route is different, but it is not the intravenous one. Yes.
Right. Question to you, Mahir, again from Ahmed Hassoun. Best timing of dosing in Ramadan. Advice?
Yes. If our patient or Ramadan, he stopped his last meal by 12 midnight, and he's awaking for suhoor, able to wait for 30-40 minutes, so probably he can take it like usual. And probably some patients find this is difficult, and he mentioned that I don't take suhoor, so probably he can take just with the break of the fast, and then go to pray, and then wait at least for 30 minutes and then take his iftar meal. I think this is the most acceptable, two options during Ramadan. There is sometimes they mention probably there is possibility of giving single weekly dose for those patients taking, for example, a small dose once weekly during Ramadan to overcome this. But in practice, probably most of the patients prefer to take it the daily dose.
Actually, there was a very nice abstract that was presented at the last GATE meeting by Dr. Ali Zahrani's group, where they did a study and they used different methods of giving thyroxine medication during Ramadan. One of them was to increase with a certain percentage the amount of thyroid medication, just to compensate for the possible poor absorption that can, if food is too close to. But what you mentioned is probably the most commonly used methods. Either use it at iftar, and you have to take it prior to the prayer, and then wait for half an hour and then eat, or after suhoor. Again, in between midnight and suhoor, and then wait for 1 hour. I think those are the two most commonly methods used.
Thank you. Yes. Right. Just a general question. Is there any relationship between living in areas with history of volcanic activity and thyroid disease? Question to all of you.
The question, if there is any in volcanic living
relationship between living in areas with volcanic activity and thyroid disease. Not to my knowledge, but
knowledge really that I don't think it has any bearing. No.
Okay. All right. There is a question about variation in T4 level between various and different labs.
Yes, I think this is a practical yes, and sometimes probably we advise our patient to perform their periodic checking of the thyroid parameters in the same lab. So at least we guarantee that the same machine, the same manpower and the same material which is used. Yes, sometimes some patients refer to me with 2 TSH done in 1 week, everyone in one lab, and there is something, different, and we need to judge to start the treatment or not. I think with this, we look for the other parameters, well, not only the TSH, we see the T3, T4, and we will see if it is, for example, just in the level of the subclinical, we have the choice to wait at least for 6 to 8 weeks and repeat again. But usually for those chronic patients, it is advisable to perform their thyroid profile in a single lab, and so everything will be harmonized.
Right. Question to Ali. What is the position of radiofrequency ablation in modern thyroid nodule practice?
Actually, I'm starting the first one of my radiofrequency next Tuesday. So I'm very keen in really getting the hand of it. We have been trying really hardly to get it in, but demand really was reluctant to cover for those procedures. Now it is covered. So we expect really that to have more cases to do. I think it's something like any other methods, that we use for thyroid nodules. Like in cystic, we have been frequently using aspiration followed by alcohol injection with variable results. Radiofrequency, the field is really growing. We're talking about radiofrequency in benign nodules versus in malignant nodules. Still in malignancy, it's not totally approved in different societies. But in centers where they have experienced microscopic papillary CA seems to be treatable with radiofrequency. But overall, for radiofrequency is considered until now the main indication, large nodules where surgery is not feasible, or the patient would not like to go for surgery, where 2 biopsies have been done and confirmed to be negative. Those are the type of nodules that could benefit from radiofrequency. Some of them that are mixed nodules also seem to respond also very well, with significant regression in the size of the nodule. So I see quite potential for this method.
I think also we also, I mean, bring the procedure to our institution, and I think with time we will have more experience, and probably we can elaborate more on those patients.
Thank you. Question to Ahmed Al-Qaisi. Is there any intervention from an endocrinologist for a patient with TED and normal TFT?
Sorry, say it again.
Any intervention for a patient with thyroid eye disease with normal thyroid function?
With normal thyroid function, well, I've seen such a patient before when they have a positive antibody. Now we treat it the same. The thyroid is already sorted from the function side. So we do treat the thyroid eye disease, classify the same classification we talked about, mild, moderate to severe, or sight-threatening. And then we go through the same medication. So the same thing. Some people may develop Graves later. Some people may never develop abnormal thyroid function. Some people may go to Hashimoto thyroiditis. So it's this is why we say the pathophysiology is still not very clear. And we're getting things slowly, you know, going up, like the teprotumumab medication and other promising medication.
Thank you. Question to Dr. Mahir. Is it better to hold levothyroxine and to fast prior to testing TFTs? Anybody, actually?
I mean, it should be done on fasting.
Yeah, this is a question, yeah.
Yes, there is some recommendation from the lab that should be done in the morning and fasting to keep the consistency for the, you know, for the checking of the periodic lab. So if the patient adhere to this, he should perform this every time in the same manner. But sometimes, you know, our patients sometimes coming in a hurry, he don't want to come next day for fasting. And he usually such patient perform the lab and come to us. It is preferably that as with like other hormonal estimation to be in the morning and fasting. And probably this is will avoid the interference with the matter of food, the matter of other medication taken by the patient, and probably, you know, it will be more advisable.
Thank you.
I agree with that, actually.
Professor Naifa, a 44-year-old male with first-degree family history of papillary thyroid cancer. Patient has only heterogeneous thyroid parenchyma on ultrasound, no symptoms. Thyroid function test normal. Is FNAC necessary? What are other necessary investigations?
Yeah, so we should also ask Dr. Khalil's opinion. But in general, because papillary thyroid cancer, majority of the time, greater than 95% of the time, is not familial, we would not recommend FNA. Let me rephrase. We would only recommend FNA if it meets criteria for FNA. The family history does not change that, okay? The only time it may change it is somebody who themselves is at high risk for thyroid cancer, not just the family history. That, you know, they've radiation from Hodgkin's lymphoma when they were younger, and you see a nodule that's indeterminate, then that, and you're wondering if it meets a criteria or not, that is something that can notch up the criteria, but otherwise, no. For this patient that you're describing, if the ultrasound otherwise looks good, it does not change the need for biopsy.
I agree with that. Yeah, I agree. I mean, we go by the ultrasound features more than the previous history. Obviously, the limit for biopsy, the threshold for doing biopsy will change, but I usually rely on the ultrasound features to decide whether a biopsy should be done or not.
So stay there. Another question for both of you. What is the best option to treat a unilateral toxic thyroid with suspicious thyroid nodule in the same side. Shall we go for FNA or surgery?
Naifa, do you want me to comment on that?
Yeah, you go ahead. I probably have the same answer.
Yeah, well, I mean, if you have a toxic nodule on one side, the recommendation and the TSH is suppressed, obviously. The ATA recommendation is not to do biopsy because the risk of malignancy is not very high. But this is not the attitude personally that I take. I rely also on the ultrasound picture because we did a small retrospective study in our at SKMC when I used to work there, and we looked at 250 thyroidectomies, and some of them had toxic nodules. And the percentage of nodules that we found with malignancy within those nodules was 12%, which is really higher than what's really reported as being like 1 to 3% or 3 to 5%. So for me, if I see a toxic nodule with suspicious ultrasound features, I go for a biopsy. This is the way I've been doing it, and it's not something that maybe by the guidelines is based on personal experience.
So I just want to add to that. It's interesting, 12%, Dr. Khalil. That's kind of cool, or not. But the way I read this question, I'm just wondering if the patient meant if they did, they had a suppressed TSH, they did a iodine scan, they have one nodule that's hot, and they did an ultrasound, and they have another nodule on the same side that's suspicious. If they're asking what Dr. Khalil was asking, answering, I agree with Dr. Khalil. If they're asking if the other biopsy should be biopsied, I think it should be, right? Because it could be exactly what Dr. Khalil is saying. You could have a unrelated, cancer there, in which case that change. I don't believe in sending people directly to surgery for anything. Bottom line for me.
Right.
Another question from Ahmed Hassoun. Is there a difference in free T4 normal range if the person is fasting or not fasting?
In the free T4?
Yeah. Normal range. Free T4. I don't think so, but not to my knowledge. However,
yes, I think we need this only if we considering, the pituitary hypothyroidism. We don't depend on the TSH and the free T4. But most of the patients, probably we are, the majority, when there is TSH is the test which is for monitoring of the dose. Yes.
I think the ranges, fasting by itself, I remember that the ranges are made in general by the lab and based on population studies rather than based on associated factors like fasting or non-fasting, or in specific conditions like pregnancy, where they have to have like assay range and then trimester specific ranges. So I don't think really being in fasting, the range will change significantly. Yeah.
Generally, actually, when patients
have an opinion, I don't.
Yeah. Okay. I tell patients to do the thyroid function test any time of the day. Especially we run a surface where there is actually no phlebotomy surface on site, and the nearest phlebotomy is around 20 minutes drive or so. So some patients will come to see me in the afternoon, and I tell them just to go and do the test back in the hospital. Sometimes they do it in the morning, they do it in the afternoon. I don't think there is any sort of difference, not to my knowledge. Okay. Question to both of you again, Ali and Naifa. Can we use radiofrequency ablation in thyroid cancer, or is it contraindicated? What happens if it is done in thyroid cancer?
Maybe I'll reiterate what I said. It's not approved yet based on the guidelines to treat thyroid cancer with radiofrequency. But a lot of centers who have experience in this procedure have been using it to treat mainly microscopic type of cancer. And that seems the results are really quite adequate, quite good. Again, I say it's operating dependent. It's a procedure that needs a lot of practice and time learning. So if you take someone like Dr. Beck from South Korea, who has pioneered this kind of procedure, he can do it blindly. I mean, he's has dexterity in doing things and experience now. So there's no issue in doing it. But by guidelines, it's not accepted. Like if you go by guideline, it's not accepted to treat thyroid cancer. But it's done. And there are studies now, published studies on treatment of thyroid cancer with radiofrequency. Even some thyroid nodules, lymph node, have been treated also with radiofrequency. But again, that something, it's in certain very specialized centers, not accepted by all the general guidelines.
Okay. I think we are running out of time. It is already 15 past 9 o'clock local. It is there any, just last question, I would say, is there an increasing risk of lymphoma to a male with hypothyroid Hashimoto's disease, heterogeneous gland by ultrasound, with increasing size of the gland with time?
So, sorry, what's the question again?
The question is any excess risk of lymphoma to somebody, to a male patient with Hashimoto, who has a sort of heterogeneous appearance on the ultrasound, and the size of the, or the complexity of the heterogeneity seems to be actually getting worse by time.
Right. I can say, I think my first publication was a case of Hashimoto thyroiditis that has evolved into lymphoma. And then actually on pathology, it's interesting to see it's like there was a separation line between the Hashimoto side and then the lymphoma. And since then, there have been a lot more publication that came into the literature indicating that the association can exist, and Hashimoto could be a precondition that can evolve into lymphoma. I think is the lymphoma present in a different way. It's usually very firm, very hard presentation. The growth is very rapid. From a gland that really was within the neck, well concise, suddenly there's a rapid growth, and then the consistency is very firm and very aggressive. One has to think about maybe lymphoma in that case. I don't know whether NIFA has different thought in this. You have seen maybe also a few cases in that respect.
Yeah, no, I agree with you. You know, the history of lymphoma of the thyroid typically presents almost like an anaplastic, right? A rapidly growing mass or airway, or, you know, so it's not that you would watch them any differently. I agree with everything that Dr. Khalil says, you know, because there's many, many patients with Hashimoto's and very few with thyroid lymphoma. And so there's no screening guidelines, right? Just like that family history of papillary thyroid cancer, even if you have 3 people in 2 different generations with papillary and you call it familial, there is no screening guidelines. So like all these things are good questions that people are asking, but we don't have that data to suggest what to do.
But lymphoma of the thyroid is exceedingly rare. I can't remember that through my career I have actually stumbled on any. Not sure about you. You have published, you said, your first case,
Right.
Ali.
I was a resident at the time, actually, and my paper was rejected 4 times until at the end they accepted it.
Persistence is key.
Yes.
I think we are running out of time. I'm sure, you know, there could be more questions, but it's already getting late. I would like to take this opportunity to thank all of you for such a wonderful actually evening, very informative, very educative, and very actually rich in science as well as in knowledge. Thank you very much on behalf of GATE. And I would like just to remind the delegates, please scan the QR code for the next, as well as just to remind you that it is an opportunity as well to join us as members in whatever capacity, whether a full member or associate member. And also please remember to scan the QR code for the feedback, because this is going to be of paramount importance for us to plan future actually, you know, and of course, you can follow the organization website in various actually sort of social media, including Facebook, including Instagram, including Twitter, as well as including LinkedIn, and you can access our website. Thank you very much again, Professor Naifa, Professor Ali, Professor Mahir, and Dr. Ahmed Al-Qaisi. And thank you again to the choice, and again, great credit and real gratitude to Merck. Thank you very much for a wonderful evening, and everybody have a very good night. Thank you. Assalamu alaikum.
Good night.
Thank you.
Wassalam.
Good night.